British Orthopedic Association Trauma Standard. Supracondylar fractures of the humerus in children. Background and justification. Supracondylar fractures of the humerus are the most common elbow fractures seen in children. They may be difficult to manage and can be associated with significant complications including nerve injury, vascular compromise, malunions, and compartment syndrome. Inclusions: children with a displaced supracondylar fractures of the humerus. Fractures in adolescents may require adult treatment strategies. Standards for practice: 1. A documented assessment of the limb must be performed on presentation and immediately before surgical treatment. It should include the status of the radial pulse, digital capillary refill time, and the individual function of the radial, median, and ulnar nerve. Median nerve including anterior interosseous nerve. Second, surgical management should be carried out on the day of injury. Nighttime operating is not necessary unless there are indications for urgent surgery, which should be documented. 3. Surgical management should be provided urgently when there is an absent radial pulse, clinical signs of impaired perfusion of the hand and digits, open injury, or evidence of threatened skin viability. Fourth, the majority of vascular impairments associated with supracondylar fractures resolve with fracture reduction. A limb without clinical signs of ischemia does not require brachial artery exploration, whether or not the radial pulse is present. Fifth, surgical stabilization should be with at least two K wires that engage in the cortex proximal to the fracture. Crossed wires are associated with a lower risk of loss of fracture reduction, whereas divergent lateral wires reduce the risk of injury to the ulnar nerve. Sixth is when a median wire is used, technique to avoid ulnar nerve injury should be employed and recorded on the operative notes. Seventh, 2 mm diameter wires should be used where possible to achieve stability. Intraoperative assessment of satisfactory stability and clinical alignment should be performed and documented. If the limb remains ischemic after fracture reduction, then exploration of the brachial artery is required, with a surgeon competent to perform a small vessel vascular repair. Ninth, monitoring of neurovascular status as described in point 1 should continue postoperatively until the treating surgeon is confident there is no risk of vascular compromise or compartment syndrome. When there is concern over iatrogenic nerve injury, then a documented assessment with a consultant input is required for consideration of nerve exploration before discharge. Suspicion of compartment syndrome or deterioration of perfusion should prompt immediate vascular assessment and intervention if required. 11th, the operating surgeon should determine and document the need for post operative radiographs and anticipated time of wire removal. 12th and last, routine long term follow up is not usually required. Any indication for further review should be documented. Thank you.